Well, welcome everyone to the first NAMI at noon of 2026. I'm Amy Brundle. I'm the Director of Marketing and Communications here at NAMI North Carolina. And as always, we're thrilled to have you in today for the webinar. First of all, of course, we'd like to thank the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Use Services for their support of today's webinar. Just a couple of housekeeping items. If you've got questions for our speaker today, please put them in the Q&A section below or the chat, and we will answer them towards the end of the presentation. There may also be some discussion questions as we go along, so feel free to put your answers to that in the chat so that we can make this as interactive as possible. If you are attending live, this course is eligible for 1 hour of NBCC credit. Those certificates will be processed probably by Friday, January 22nd. So if you haven't gotten your certificate before then, just be patient with us. We'll get it to you as soon as possible. And now I'd like to introduce today's speaker, Desiree Gorbea-Finalet. She came to North Carolina from Puerto Rico in 2017, bringing her passion and tenacity with her. She joined Disability Rights North Carolina in September 2021 as the Traumatic Brain Injury Justice Initiative Project Manager, which is quite a title. Her work centers on developing and implementing an innovative traumatic brain injury screening and support services initiative program in various community-based service settings in North Carolina. Her passion for disability rights advocacy stems from her lived experience with multiple disabilities. She has a Master of Arts in Peace and Conflict Studies with a focus on international peace and development from UNC Greensboro, and a Bachelor of Arts in Psychology and a minor in Criminal Justice from the Universidad Interamericana de Puerto Rico. Welcome, Desiree.
Thank you, Amy, and welcome everybody. I hope everybody had a great holiday and Happy New Year. I appreciate NAMI for giving me the opportunity to be here and present on the topic of brain injury and mental health. So we're going to get right into it because we have quite a bit to cover, but fear not. The presentation will be sent out to all registrants after the webinar is over. So don't feel like you have to take so many notes. Uh, you will have this in your inboxes afterwards. So as Amy introduced, my name is Desiree Gorbea-Finalet, and today I'm going to be talking to you guys about understanding the association of mental health after a brain injury. And then in that, we're going to be talking about how screening to identify brain injury addresses the increased risk factors for mental illness. So I want to provide a quick trigger warning for anybody because we might talk a little bit briefly about substance use and of course mental illness and just certain sensitive topics that could include intimate partner violence, criminal legal, and just certain issues that may be sensitive for certain viewerships. And we want folks to take care of themselves. So if this is sensitive to you, please use discretion as advised. So Disability Rights North Carolina, for those of you who have never heard of us, we are the federally mandated protection advocacy agency for North Carolina. We handle cases involving discrimination, abuse, and other rights violations. We are a special agency because we are the only one in our state that does this. We are at no cost to all North Carolinians with disabilities. We are independent 501c3, so we're a nonprofit. We're part of the National Disability Rights Network. We work to challenge and change policies, practices, and structures that result in widespread injustices or inequalities for disabled people, which is just a really fancy way of saying that we work to help people who, in the system of healthcare and just general things that they might go through on a day-to-day basis, might face some level of discrimination or other rights violations. We help people across the lifespan, so that could be from child all the way to elder, of any type of disability, mental illness, it could be physical disability, neurological, any type. And we also help with providing resources and guidance to empower individuals to advocate for themselves. Some of the areas that we focus on are education, housing, health and mental health care, community access support, voting rights, and juvenile and criminal legal system. There are certain areas that we cannot assist with, but that can be found on our website at disabilityrights.org. So, a quick overview of our session. We're going to have four sections that we're going to go through. And again, you don't have to take notes on anything. This is all going to be sent to you. So, I want us to set the groundwork to think about brain injury as a disability, because it is, that overlaps with a lot of other disabilities that many of us here, whether we're providers or whether we are people with lived experience or caregivers or people who have some level of interaction with whether it be mental illness, behavioral health, substance use disorder, we may have interacted with people with a brain injury because I'm willing to bet most of us have had some interaction with people with a brain injury or substance use or mental health, and setting the groundwork for letting people know that brain injury is much more prevalent than we realize, and which we'll learn why, and that it overlaps with many of these other disabilities. So I want to ask folks to put in the chat um, just what their thoughts are. What signs and symptoms do you attribute to a brain injury? It could be a simple word, a sentence, just a symptom, anything. It could literally be anything. What do you as the viewer attribute to a brain injury? I see someone brain processing issues, loss of skill they previously had, confusion, memory loss, change in personality, irritability, speech, memory. Yeah, those are all great. Wonderful. Emotional ability, wonderful. Great. Ear ringing, those are all great. Developmental delays, impulsivity, headache, confusion, fantastic. Awesome. Thank you. So all of those are part of that. Great. So let's keep that in mind. So I'm going to start with brain injury is much bigger than what a lot of us even think about. So we're going to look at brain injury at the top of this chart, and then it stems out into multiple different things. So we have injury from degenerative disorder, which is out on the left side because there is disagreement within the brain injury research and medical community whether or not these are completely separate entities. However, a lot of the symptomatic responses that people who experience, for example, these are just examples, Alzheimer's, Parkinson's, multiple sclerosis, things like that, like these neurodegenerative disorders have a lot of symptomology that is very similar to those who have traumatic brain injuries and non-traumatic brain injuries. So that is why in some brain injury research, they do classify them as non-traumatic. However, some do classify them as completely separate. But I do put them here simply for the purpose of the fact that they do have some symptomology that do overlap. And then we have congenital brain injury. We have injuries that occur to an infant, a baby, in the womb or during birth. So we think of fetal alcohol syndrome, think of any type of genetic abnormality, and then we have what we most know as a brain injury, acquired brain injury. Acquired brain injury is the major umbrella term for traumatic brain injury and non-traumatic brain injury. I don't want the term non-traumatic brain injury to have people think that it's not a traumatic incident. It's just how the brain injury was acquired. So we have here traumatic brain injury is injury that is caused by an external force, and then non-traumatic is injury caused by internal factors. So we're going to think of non-traumatic brain injury, for example, is a hypoxic and anoxic example, which we'll see in the next slide. An example of a non-traumatic brain injury as well is an overdose, an aneurysm, a stroke. I saw somebody mention that in the chat. And those are just examples. And then we have hypoxic brain injury as partial deprivation of oxygen. And an example of that is carbon monoxide poisoning, near drowning, smoking inhalation, strangulation. And then we have anoxic brain injury as complete lack of oxygen to the brain. So think of like someone who has completely lost oxygen to their brain. And when we look on the opposite side of non-traumatic, we go to the traumatic side of brain injury. Primary injury, so damage that occurs immediately due to the accident or incident, I'm sorry. We have penetrating, so that's open head injury, an injury that breaches the skull. So think of like perhaps a gunshot wound, any type of skull fracture. And then we have non-penetrating closed head injury, which is damage caused by the brain moving inside the skull. So think of like a jello. Think of a piece of jello, maybe when you give a child like a piece of jello in a cup and you can move the jello really, really fast. A non-penetrating closed head injury is when the brain moves really, really fast inside the skull. That is still considered a closed head injury. So for those of us who know someone who's had a concussion, that is a mild traumatic brain injury. And that is something that most people are not aware of. So impact, an example of that, that's more of an extreme example, is impact from an explosion, whiplash. Whiplash is something that tends to happen a lot in car accidents, but often gets overlooked. And then we have secondary injury, delayed damage that occurs due to the effects of the primary injury. So we have cerebral swelling as a more extreme cause, and then we have second impact syndrome. So typically, people who have long-term effects of some type of brain injury, some type of TBI, and then also something we see a lot is post-concussive syndrome, often that we see when people have concussive events that have symptoms that last much longer than expected. So the brain lobes we see here, we'll go over them quickly. We see the frontal lobe, the parietal lobe, occipital, and then the temporal, the brainstem, and the cerebellum. Each of these lobes, and even the brainstem and cerebellum, they all have a key functioning to the functioning of the brain and the human body. So think about all those answers that you guys mentioned about what signs and symptoms you attribute to a brain injury. All of you were right. And all of you, without realizing, attributed those things to different parts of the brain lobes. And one of the biggest things that I hope folks can take away from today is that most people, the average folks who have a TBI, specifically a TBI, and not just a TBI, but even non-traumatic brain injury, they have issues with executive functioning, which is what we see here affecting in the frontal lobe. People who have issues with thinking, problem solving, emotions, and general cognitive deficiencies. So, where brain injury can be found is people with a brain injury. We see people with a brain injury in any of these spaces, for example. So, folks with a brain injury can seek services at a domestic violence shelter, being unhoused, being in correctional settings. They can be in the military, whether active or veterans. They can be in sports, child, adolescent, or professional sports, or college, at home. That's something we see all the time. Falls, child, or even domestic abuse, or even a child that's just playing. It doesn't have to be abuse. Sometimes the child's just playing. Transportation, that's such a common one. Car accidents, and often gets overlooked. Assisted living in nursing homes, sometimes um, mental health treatment centers, substance use treatment centers. All of these places are places where people with brain injury exist. And oftentimes we don't realize how common a brain injury is because we don't realize how invisible the disability looks. So, what are the changes that happen after a traumatic brain injury? The changes that happen after a traumatic brain injury depend on which areas of the brain are affected and the severity of the injury. So somebody can have a brain injury, that they had an injury, for example, on the side of their head, but the part of the lobes on the left side are what's affected. It depends. Every person is different. And if you've seen one brain injury, you've just seen one brain injury. Not every person's the same, and not every person reacts the same. I always say that there are at least 5 to 6 major changes: cognition, emotional, communication, behavioral, physical, and sensory. And we can chalk up emotional and behavioral to the same thing, which we'll see in this next slide. Here are some signs and symptoms, some physical symptoms that we see, and this is just a small list. There's much more. Some physical symptoms I commonly see with individuals, with other survivors and caregivers that people report are headaches. Some sensory ones are visual and auditory, language and communication, people who develop aphasia, especially after a stroke, the inability to have spoken language or written language. And a very big one, cognition, cognitive changes. My goodness, it is a huge part. People who have issues with executive functioning, processing information, and behavioral changes, which is where we see those aspects of mental health coming in. So people who develop some level of mood swings, anxiety, potential depression, and even sleep changes. Some we have listed here excessive drowsiness, but some people even develop high levels of insomnia. Some red flags for brain injury to have lasting effects, according to the Substance Abuse and Mental Health Service Administration, is that it depends on when the brain injury happened, age, the severity, and how often. So, like I mentioned, all of those factors play a part in how a brain injury can affect the person long term. So, when we think about recent injuries, if a mild brain injury in the last few weeks, moderate in the last months, and severe in the last few years, multiple brain injuries, cumulative effects. So, we see that in a lot of sports. So, if someone has two or more TBIs put together, if we see developmental brain injuries happening before the age of 20, if we see one moderate or severe brain injury anytime during life. So again, there's mild, moderate to severe, which we see based on the Glasgow Coma Scale, and that is based on how long was the person unconscious, and and that's for TBI specifically. Something a lot of people don't realize is that you don't have to be unconscious to have a concussion. So someone who is unconscious from 0 to at least thirty minutes is still considered a mild traumatic brain injury, and you don't necessarily have to be completely unconscious for that. So some risk factors for increased disability is a history of a previous injury. Most people don't realize that they even had a history of a previous injury that was never addressed or treated correctly in their childhood or adolescence. Sometimes they were told to just walk it off or rub some dirt on it, or they were even told, hey, you got your bell rung and it's not a big deal. You're okay. There's no blood. There's nothing, no broken bones. It's okay. Maybe they had issues with access to healthcare or insurance, or they lived in a rural place. We see that a lot. Pre-injury mental health disorder or post-injury development of a mental health disorder, which we'll talk about. Increased risk of developing substance use disorder later in life. Development of neurological disorders, so people can are at higher risk of developing sleep disorders or at higher risk of developing seizures or epilepsy. They're at higher risk of developing other types of neurological disorders in addition to just having a brain injury. And if they had exposure to child abuse. So when we're thinking about all of these aspects that I just mentioned, what are the complications of a brain injury? Well, most TBIs, so traumatic brain injuries, we're not even thinking about non-traumatic brain injuries. We're just talking about TBIs for a moment. 75% of traumatic brain injuries across the United States are mild. And those, even though the word I said mild, the symptoms can lead to lifelong impairment. They're often not visible in a CT or MRI scan, specifically the mild traumatic brain injuries. We can typically only see those that are moderate to severe. And 90% of concussions are not associated with the loss of consciousness, like I mentioned earlier. And 90% of concussions go unreported, which again goes in line with many anecdotes that most folks say of I got my bell rung, or I fell down, or I was playing as a kid or a teenager and we didn't think of it. It wasn't a big deal. I didn't hurt myself that much. Brain injuries can be invisible and they mirror other disabilities or conditions. And concussive symptoms can develop over days and persist months and into years. Oftentimes, I've seen some folks who develop concussive symptoms within days and weeks, and they don't realize that those are concussive symptoms simply because sometimes they don't know. Sometimes, even when they go to the doctor, even the doctors themselves don't know because the awareness of brain injury is still very much developing. So, when we think about the impact and magnitude of traumatic brain injury in North Carolina, the North Carolina Department of Health and Human Services put out a report in 2021 where they looked at back in 2019 the percentage of annual TBI related deaths and hospitalizations and emergency department visits. Um, they found that the main cause of deaths were firearms were 43% according to the reports they had, and hospitalizations were at 53% based on falls, and then emergency department visits were at 42% from falls. So we can hypothesize that those could have been perhaps when it comes to falls could have been from different groups, adults, elderly. And then TBI related deaths by age and sex. We see male and female. We see males having a higher related TBI related deaths in 2019, according to our Department of Health and Human Services, with a high fluctuation in the age range of 35 to 44 in males. And then again, we see that at 75 to 84 and then 85, where we see the men having a death rate in those specific age ranges. And it could be for a high variety of reasons. Could be that the elderly could be related to falls, could be a variety of things. So when we think about brain injury and co-occurring conditions, I list this graph right now because I want us to think about brain injury is one of those things where it's kind of like the chicken and the egg. Which one came first? Brain injury does not necessarily mean that someone will develop substance use or behavioral health, nor does it mean that someone who has behavioral health or substance use has a brain injury. It does not equate one or the other. But, however, to give a holistic overview of someone, it is best to identify when seeing someone, is it possible that someone who has a brain injury has history of substance use or history of behavioral health and vice versa? Does somebody who has behavioral health or substance use or alcohol use disorder have a history of a brain injury that was never identified? And the reason for that, which we'll see later, is that it could impact how they are working and how they are being successful in their treatment plans. And then TBI is common but often undiagnosed co-occurring condition, specifically, which we see a lot in substance use disorders. And then with mental health, almost half of adults with TBI have no pre-injury history of mental health problems, but develop mental health problems after a TBI. And so we see that people with brain injury that may not have had mental health problems before, they start to develop them within at least 1 to 2 years, and then suicide tends to increase exponentially on folks who do actually sustain a brain injury. And the risk for and a trigger warning for completion of suicide is 2 to 4 times greater in individuals with TBI than the greater population. Even mild traumatic brain injury increases that risk. So think of that 75% across all of the United States. And then when we combine mental illness and substance use together with TBI, the risk for attempted and completed suicide is further increased. And we're going to see what those numbers look like momentarily. So, vulnerable populations of brain injury is really important when we think about this because we're talking about mental illness. And for those of us who have suffered with mental illness, we know how important and sensitive this topic is for those of us who know someone very close to us or who have suffered through it ourselves. Um, TBI with loss of consciousness in the general population of non-institutionalized adults is 22%, and moderate to severe is 5%, but substance use treatment settings is 53%, and then psychiatric inpatient is 36%, and those incarcerated are at 50%, and those unhoused are at 47. Those are exponential numbers on those who are vulnerable populations. And then we see moderate to severe greater than the general population. So, health disparities, we know that there are some groups at greater risk of dying from brain injury and experiencing long-term health problems. And those are racial and ethnic minorities, justice-involved people, people who are survivors of intimate partner violence and child abuse, people living in rural areas, and people experiencing homelessness. And so when we think of all those things, I want us to think about how I set the groundwork for why mental health is something that can mirror and be a part of brain injury, but why does it happen after brain injury is what I want to explain to us. And so I want to ask folks, what signs and symptoms do you attribute to mental health? And you can put a word or a sentence in the chat. Psychosis, mood swings. What about taste and smell? Yeah, taste and smell absolutely do change after a brain injury, if that's what you meant. Isolation, sad ups and downs. Yep, I'm glad you mentioned that. Anger, changes in behavior, anxiety, shift in behavior. Great. These are fantastic. Wonderful. So, what happens when someone has a brain injury? So, brain injury and mental health. According to SAMHSA, there is an association between TBI and behavioral health comorbidities because depression, anxiety, substance use disorder, and increased suicidal ideation tends to happen at exponential amounts for those who have a brain injury. And an exhaustive review found that the incidence of major depressive and post-traumatic stress disorders exceeded population rates after TBI, commonly emerging in the first year. However, onset could be delayed with more severe injuries. So within the first year, we see that people with a brain injury tend to develop these mental health symptomology responses, and it starts oftentimes with anxiety, and then it trickles down into depression. And then sometimes we see people developing PTSD, depending on what was the cause of the accident, or I'm sorry, incident. And then sometimes depending on what type of brain injury they have. And if it goes unnoticed, even suicidal ideation. So, why might someone develop a mental health disorder? Physiological changes, which I think somebody mentioned in the chat, damage to the structures and physical parts of the brain and the head, impact to biochemical parts of the brain impacting neurotransmitters. So someone is developing these things, these changes because they're essentially their brain has changed. There's life changes, personality changes. Someone mentioned that in the chat, health changes, environment, interpersonal struggles, and also they've experienced some level of trauma, whether it be a traumatic brain injury or a non-traumatic brain injury. And sometimes I do want to mention, even a stroke is a traumatic event. And there's sometimes previous unaddressed trauma that people have not gone through the proper ways of healing. And that can also contribute to developing a mental health disorder. So when we think about the psychosocial impact, there's interpersonal difficulties. Establishing and maintaining relationships, people start to develop uh, an inability to pick up on nonverbal communication, spoken words and gestures. So they start to be unable to kind of socialize in the way that maybe they were used to before. They start having interpersonal difficulties. They start maybe experiencing a loss of self-esteem, a lot of self-talk reflection, maybe um, uh, self-degradation, shaken sense of self, ability to have emotional regulation, which emotional regulation is part of that executive functioning we talked about. They start to experiencing anxiety and depression. And then neuropsychiatric disorders that happen before brain injury is typically a precursor if there's a pre-injury disorder. So if someone had an injury before, I'm sorry, if somebody had a disorder before an injury, for example, um, it's a strong predictor of a post-injury disorder. So say somebody had a diagnosis of depression, and then they got into a pretty bad wreck, a car accident when they were 22, hypothetically. A significant number of individuals with TBI are diagnosed with a new onset of neuropsychiatric disorders, creating what we call a dual diagnosis. So that individual that I gave as an example that got into that wreck at 22 years old, that already had a diagnosis of depression from when they were a teenager, could develop now even more chronic depression, post-traumatic stress disorder, and or other disorders. And then pre-injury diagnosis found that in a study of 100 participants, they use the structured clinical interview for the DSM, found that 52% of the sample received a psychiatric diagnosis pre-injury. So we see that there's a lot of incidents of people who've had a pre-diagnosis pre-injury. So it's pretty common that folks have some level of a diagnosis pre-injury. So like I said, it's the chicken and the egg. Which one comes first? So, some mental health concerns and brain injury. A list of mental health disorders is depression, PTSD, substance use disorder, schizophrenia, anxiety, and personality disorders. And then I have some statistics here, but I really want to highlight the main ones that I have tend to see in folks and that folks have reported not only in research but also anecdotally, and that the average patient and survivor will be diagnosed with major depressive disorder or anxiety disorder within 2 years of their incident, whether it be a traumatic brain injury or a non-traumatic brain injury. And more than 50% of general brain injury patients are at risk for developing major depressive disorder within the first year. So we see these folks developing anxiety and depression at such higher rates in such a quick fashion that one of the main things that I think is the most important thing that we can take away from this is that screening for mental illness consecutively within the first 5 years of seeing patients is so critical to make sure that we are taking into account not only their mental stability in the moment, but also how they are in the process of recovery and rehabilitation. And some other neuropsychiatric disorders that we see are bipolar disorder, obsessive compulsive disorder, and subodobular affect, which is PBA, which is a neuropsychiatric condition characterized by sudden involuntary uncontrollable laughter and or crying. And it's often disproportionate or inappropriate to an event or situation. We see that bipolar disorder is at 2 to 9% in the following year of an injury, and OCD is often pretty low in a diagnosis following a TBI. Um, and we see that PBA is actually often uh, diagnosed in those with a stroke. So when we think of, we looked at neuropsychiatric disorders pre-brain injury, but then we have to look at after brain injury. So those diagnosed within first year of an injury are commonly diagnosed with mood disorders, anxiety disorders, substance use related disorders, and or addictive disorders. And again, like I said, it doesn't mean that somebody with a brain injury is going to be diagnosed with any type of mental illness and or substance use disorder. It just means that they have a higher risk factor for those other disabilities just because of the changing physiological structures of the brain, exposed to trauma, and also changes in personality. So those are all factors that make them have higher risks for those things. Doesn't mean that it means this equals that. And then a commonality of mental health disorders is that in the earlier study I mentioned in the slide of pre-brain injury is that 60.8% of the study sample received that a neuropsychiatric diagnosis, predominantly mood and anxiety disorders, within the first year post-injury, which goes in line with a lot of what I mentioned earlier. And so, um, I do want to mention that one TBI has an increased severity for substance misuse, and then earlier age of substance use, and then a higher likelihood of other disorders. Um, so when we think of dual diagnosis of brain injury and mental health, the symptoms of co-occurring disorders, brain injury and mental health can overlap and may worsen the course of both disorders. And it can be challenging to determine whether presenting symptoms are the direct result of brain injury or a normal reaction to an injury. So we see a lot of people experiencing brain injury and mental health, and just the symptoms overlap, which we talked about earlier. And I mentioned earlier about suicidality. Co-occurring mental health substance use risk with TBI increases the risk for attempted and suicide completion. And I want folks to keep this in mind and can remain elevated for up to the 15 years post-injury. So folks can experience suicidality for up to 15 years post-injury, and the risk for suicide is 2 to 4 times greater for individuals with TBI than the general population. And that is according to the Substance Use and Mental Health Services Administration. And those numbers are very staggering to hear. And I asked those questions earlier about what folks attributed to brain injury and mental health, because here we have the kind of like that Venn diagram, one of those that we did as children. Um, and we see that on the brain injury side, we have some of these symptoms, and then we have mental health side, which all of you have mentioned wonderfully. And then we have this in the middle, all of the ones that coincide that are shared between the two, which are very similar. Confused thinking, extreme mood changes, trouble understanding and relating to situations, behavioral responses, suicidal thinking, significant tiredness. So when we're thinking about all of those things, um, I want us to think about, what are some best practices for engaging with an individual with a brain injury, you know, um, and can it be treated? Um, Different from treating a mental illness, where we treat it with pharmacological intervention and therapeutic interventions and group therapy and individual therapy. Brain injury is treated in a different way in that you're treating the deficits and challenges of the brain injury, and that there's no known cure. You're looking to enhance and accommodate neurocognitive challenges for the person, which we're going to talk about in a second. And some mental health and brain injury treatment barriers are behavior regulation, memory issues, attention and focus in sessions or in a classroom or in workspace, low self-esteem and motivation, communication, and initiation. So somebody might experience barriers in wanting to seek care because of some of their not knowing that they're experiencing mental health issues because maybe they don't have a word for it, maybe they've never sought care, maybe they don't even realize that what they're experiencing is mental health. And I do want to mention that sometimes there are some people with more severe cognitive challenges because of a brain injury, that neuropsychology could be an avenue that folks should be referred to by doctors for assessments to evaluate the cognitive deficits of an individual to develop individualized treatment plans. So, when we're thinking about how to address mental health and brain injury together, I really want to drive home that conducting routine mental health assessments regularly within the first 3 to 5 years that physicians are seeing patients is critical, whether it be a primary care doctor, neurologist, therapist, psychiatrist, um, on a regular basis, at least every, 6 months to a year, more ideally, but at the very least, a few times a year, because you never know where someone is at, and consistent mental health assessments should be implemented at least in every visit, but sometimes they might not be, but at the very least, a few times a year, simply because you never know where someone's at. And psychotherapy and behavioral therapies could be options for folks, skill-based interventions and pharmacological interventions. And then SAMHSA also recommends that some counselors, specifically those who provide services, therapeutic services for people with brain injury, not just TBIs, screening for the history of TBI, creating, and because of screening for TBI, so helping identify brain injury, can create accommodations for neurobehavioral deficits from executive functioning, which is what I mentioned earlier, creating holistic approaches for comorbid conditions, and creating formal and informal supports available during and after treatment completion. So basically creating ways where folks can learn how to accommodate themselves during treatment and afterwards. So some therapies that have been found to be helpful for folks with brain injury is CBT, EMDR, ACT, for example, to start with. And for sake of time, I'm gonna just go through these next slides pretty quickly, but keep in mind you will have access to the rest of the slides. So, positive psychology and brain injury is something that I do like to implement with folks that I work with, especially in support groups, because I like to focus on the strengths and well-being rather than solely on deficits. Because especially with people who have experienced a brain injury, um, people who experience a brain injury often tend to focus on the things that they have lost. Um, and it's important to bring them back to learn that it's not so much things that have been lost, but rather things that, while it's important to grieve and give and honor that time, it's important to learn how to focus on how we can re-understand this new rebirth, if you will. Um, and it helps cultivate strengths and positive emotions and help lessen anxiety and depression and be able to use available resources and perceive a positive outcome, even in some of the most traumatic moments. And for those professionals who are on the call today, here's some interventions that can be used that have been found to be helpful for folks. And you can take a screenshot of this, and I have another one as well for helping folks cope with coping tools. And a lot of these are available for um, children, adolescents, and adults as well. Um, and the idea is to provide professionals with more information on how we can use more intervention tools to help identify where individuals are at in terms of their mental health and where they are in their self-understanding of their brain injury. So some strategies providers can use with brain injury survivors is screening, accommodations, and helping to create those accommodations, and understanding that they may have comorbid conditions such as mental health disorders that we talked about, chronic pain, sleep disorders, and substance use disorders, and creating formal and informal supports that they may need. And so the impact on executive functioning is that a lot of people will have an impact on working memory, flexible thinking, and self-control, and these are essential for everyday tasks. A lot of us don't realize that a lot of these everyday tasks are affected by executive functioning. And some of these, just to list a few, are prioritizing tasks, problem solving, time management, starting and completing tasks, and regulating emotions, having self-awareness, and being able to control impulses. And one of the things that I want us to think about with all of the aspects that I've mentioned is the importance of screening and mental health. And the reason why screening for brain injury and encompassing mental health is that we want to see if someone who may have a mental who may or does have a mental illness has potentially a lifetime history of brain injury, because a person may be eligible for community-based services. It can help a provider understand how to work with someone with a brain injury, and it can help individuals understand um, maybe an injury that they had and how that impacts them. And ways that brain injury can improve a client's quality of life is that it can distinguish from other disabilities. We can try and implement accommodations, make timely referrals, and facilitate appropriate engagement. And then, depending if someone's in a specific treatment setting or facility, it can actually help to enhance safety by understanding what are the areas that they are needing specific help with, if there's a behavioral aspect that needs to be considered. And so, this the aspect that I want to mention to the folks on the call is that Disability Rights has a current campaign available to the state of North Carolina, which is NC Brains, which provides a free brain injury screener for folks to screen themselves or for providers to screen either patients or clients on brain injury. So you can scan the QR code and learn more about our program. The QR code sends you to our website, and it's a campaign aimed at facilitating advancements in provider education. So we provide trainings for free across the state on brain injury 101, brain injury mental health, substance use disorder, vulnerable populations, a variety of things. And you can submit a request online for additional trainings, and we do the trainings virtual or in person. And we also have, like I said, a free brain injury screener. And in that brain injury screener, there is a symptomology questionnaire for those who screen positive on for having a history of a brain injury. And it does have some questions on behavioral health and mental health. This is not a diagnosis of a mental health disorder or a diagnosis of a brain injury. It simply helps to potentially identify if there is uh, a history of of a brain injury that was never identified, and it could potentially be used to take back to your doctor for further evaluation. Again, not a diagnosis, but you can take the results back because it is an evidence-based tool that has been validated because it was created at Ohio State Medical. And I want to share with folks the QR code to our screener if folks would like to start accessing our screener, and our subscriber name is DRNC, and then our code is 919. And then I will leave the QR code there for folks to scan it. And I just want to let folks know either providers can screen folks, individuals can screen themselves, or they can actually submit a request to be screened by me, or we can guide you into how you can screen yourself if that's a preference. We also have paper versions of the OBIS, and then we also have different mechanisms for folks to screen themselves if they want to, like I said, call in, submit a request. And for providers that want additional trainings, we also have that available. And I'll put this on the screen really quickly. If people are wanting to refer someone for screening, whether yourself or a loved one, on the website, you can send a referral for a screening there, for our NC Brains tab. But again, this screening is completely free and your information is de-identified, so you don't have to worry about your information being sent out anywhere inappropriate. And we can, and then after you, if you screen positive, you will get materials and information on your areas of challenges as a person who took the OBIS. And they look like this. These are the toolkits that you get, and they look very similar to this. And then if you're a provider, you get the same thing, but from the provider standpoint. It's a fantastic tool, and I've been using it with multiple different settings, and I'm very happy with it. And I'm happy to answer any questions and or put my email in the chat, which I will. And you guys will get the slides. And I will leave this here, and I'm happy to answer any questions.
Desiree, thank you so much for this presentation and for just really being thorough but organized in how you kind of laid this out and gave everybody a really good outline of what they could be looking for in their family members and their clients. I have a question just to get us started. Now I know that your screening is primarily for providers, but do you all offer any resources for maybe just family members or caregivers who are wanting to better understand the person that they are providing care for?
In what sense, like more information like about brain injury or more information on like resources in the state?
Yeah, I think resources that may not have been written for a provider necessarily, but still give a good outline and good information on, my family member is experiencing this and I'm not sure how to help. Here's some things that can help me understand what they're experiencing a little bit more so that I can be a support system.
Yeah, that's a great question. So I don't particularly have that information, but I know that the Brain Injury Association does, and I actually have a direct contact with the Brain Injury Association. And so what we do is that we partner together so that when I have folks that come to me, particularly asking for resources as caregivers for their loved ones, we actually create a system where we send out resources for those caregivers and loved ones because they have toolkits specifically for how to basically, I don't want to say the word teach, but basically provide information on what it's like to have a loved one with a brain injury. And then I facilitate two support groups with the Brain Injury Association. I facilitate the legal support group, and then I facilitate the Spanish speaking support group. And so with that, we constantly are in conversations about, what support groups are happening in the state. And one of the things that I highly recommend is that if there is someone who is wanting more information, come to a support group. You don't have to
Hmm.
talk. You don't even have to turn on your camera. Just listen on, and there you would be so surprised at how welcoming, number one, and number two, the amount of information that survivors teach other survivors, both
Mm.
in like what physicians are available, what therapies were helpful, what coping strategies were helpful, and also what caregivers can teach other caregivers to help cope with working with their loved one. I
Hmm.
am always in shock at how helpful support groups are when people give them the chance. And so the Brain Injury Association has wonderful materials to teach caregivers, but also support groups are one of the number one things that I highly recommend.
Yeah, that's a great segue for me to actually put our NAMI North Carolina helpline information in the chat. If you're interested in looking for NAMI programming that does uh, address mental health, especially those support groups, and want to find one near your area, you can call our helpline or contact them by text or email to find one of those NAMI groups near you that may be able to help. But Brain Injury Association, I agree, is a huge resource for people and their families. We
Yes,
had one question come through that says chronic Lyme disease is not recognized as a TBI. However, it is a brain injury according to the Lyme experts. Do you have any thoughts on this, or do you know about this infection?
I do know about the infection of Lyme disease. I have never heard of it fall under brain injury. However, that doesn't mean that it doesn't, because there are a lot of things that are falling under brain injury nowadays. For example, long COVID. I just recently found out through going through continuing education that long COVID now is considered a non-traumatic brain injury. So I would not be surprised that Lyme disease is now considered a type of brain injury. Um, Now, what are my thoughts on it being considered one? Honestly, I would have to do more continuing education on that. So I appreciate you bringing that to my attention. But I am familiar with the disease and some basic intricacies of these symptoms. So I think I need to brush up on more about that. So thank you, Robert, for bringing that up to me.
Yeah. Well, we want to thank you again so much for this incredibly informative presentation. I hope that all of our audience found this to be really helpful when informing either their practices or just their understanding of mental health and how broad it is and how it can be impacted so many different ways. Um, we encourage you to keep an eye out for an email by the end of the week that will have these slides and Desiree's contact information and the recording of the video. And then if you are attending live, you'll have those CEU certificates by next Friday. I think I said the 22nd. That's not the correct date. It's next Friday. So I'll have that to you in about a week and a half. Also, we ask you to keep an eye out for information about our next NAMI at noon taking place on January 28th. We're going to join Emily Barnhart for a discussion on the impacts of human trafficking on mental health and what providers can know when they're treating survivors. Look for more information about that in our newsletters and social media. Until then, again, Desiree, it was lovely to have you. Thank you so much.
Thank you, and I appreciate everyone being here. And if anyone has any questions or just wants to run something by me, please feel free to email me. It's an open book here.
Excellent. We'll thank everybody for showing up and have a great afternoon.
Thank you, everyone.